So with this lecture, we are going to talk about the postoperative part of the perioperative experience. Hopefully you've already watched the preoperative care video and have interacted with the activities that I've asked you to do for the intraoperative portion of perioperative care. So now we're ready to move on to postoperative experience. Okay, so primarily what we're going to talk about when we talk about postoperative care are the different things that we're going to be monitoring for that could go wrong. So before I kind of get started jumping into that content, I'm just going to kind of go through what happens when a patient comes back from post-op care or comes out of surgery. So initially the patient's going to go into PACU. That's the immediate postoperative period. The patient is very vulnerable at this time. They're likely just waking up from anesthesia. The anesthesiologists are pretty good about timing their medications and doing their calculations so that the patient wakes up right when surgery is expected to end. Depending, on how major or minor the surgery is, the patient will wake up pretty quickly in that immediate postoperative period. Excuse me, airway is always a priority. If you ever go and observe in PACU or anything like that, that's really what their main priority is ABCs. They're constantly monitoring airway and breathing, checking vital signs, checking blood pressures, that kind of thing. So once that patient has gone out of that immediate postoperative period, they're starting to wake up a little bit more. They're returning to baseline. Their vital signs are stable. They're answering questions. They're telling you about their pain. They're complaining of nausea. They're feeling just fine, whatever the case may be. When the patient is stable, they're ready to go to med-surg. Now, not every patient that comes into the PACU will go to med-surg, but just, depending on where they're going to go, if they're going to go to critical care, they might be recovered on critical care because that's more highly monitored. But for our purposes today, we're going to talk about med-surg placement. So once the patient's stable, they're going to come out to med-surg for an extended postoperative recovery period. And during that time, the nurse is going to continue to monitor vital signs, airway, breathing, circulation, that kind of thing. Look at dressings, check any tubes or drains that the patient might have. But we're monitoring them frequently, every 15 minutes for the first hour, every 30 minutes for the next hour, and then every hour for the next 4 hours. That's pretty standard. Patient extended postoperative recovery is about 4 to 6 hours or so. Now that's speaking to an inpatient setting. Another option is when we talk about in our last lecture about ambulatory care. A patient will come out of surgery into that postoperative recovery area, and as soon as they're stable, they're pretty much going to go home. That may be very short, just a few hours, and they're going to continue kind of waking up at home where their family is going to take care of them. That's another reason why patients who have surgery in the ambulatory care centers have to be pretty stable with very minimal, if no, medical history, just for their safety, because they don't stay in those ambulatory care centers all that long. So when we're doing our postoperative assessment, we really should be doing a full head-to-toe assessment, which, we have something to compare that to, because before the patient went to surgery, we did a preoperative assessment, or somebody did, and it's documented. So at this point in time, now we're looking to see how our current assessment compares to our previous assessment. Now, some things are going to be expected. For example, a patient preoperatively was likely very alert and oriented, right? Postoperatively, it's suspected that a patient may be very drowsy, maybe even a little bit confused. And while those are not normal findings, they're expected findings. So that's something that you need to kind of come to terms with the difference between what a normal finding is and what an expected finding is. Another example of that, if a patient went into surgery, let's say to have a routine hysterectomy, they may not have been having any discomfort prior to surgery, but after surgery, they're having pain and perhaps some bleeding, some vaginal bleeding. Now, before surgery, that may not have been the case, but it is expected after the type of surgery that they had and the fact that they had surgery that those findings will be true. So as you go through all the different post-operative assessments, kind of ask yourself, is this troublesome, right? Am I thinking of a complication here? Or am I really dealing with something that is expected? Okay, now so we have to be careful with lines too, right? A patient might be drowsy and their respirations might be slowed after surgery, but at what point do we become concerned, right? That's kind of what we're going to talk about today. All right, so you've got your patient back on the floor. You're doing your head to toe assessment and you're monitoring them for signs and symptoms of complications. So if you have your little post-operative sheet, this is the primary things that we need to be worried about with caring for post-operative patients is the complications. So let's start with some GI stuff. That's really pretty common. Nausea and vomiting is pretty expected and common after surgery. And of course, it's not a normal thing. Patients don't like to feel nauseated. They don't like to vomit, but it just happens. Oftentimes it's in response to anesthesia or pain medications that we're using to control the patient's discomfort after surgery. Anesthesiologists will often administer an antiemetic near the end of surgery or during surgery so that they are less likely to experience post-operative nausea and vomiting, but the fact remains it's very common. Patients typically experience nausea and vomiting afterwards. And this is that feeling, right? Most of you have probably been nauseated, that feeling of just feeling sick to your stomach, right? Just feeling queasy. Odors can exacerbate the feeling. Looking at something that just grosses you out can make you nauseated. Sometimes even there might be an element of like a vertigo, right? Where a patient starts to feel dizzy and lightheaded. And then that kind of triggers that nauseated feeling. So lots of different things can contribute to nausea. And vomiting we're concerned about, of course. It's uncomfortable, number one. Nobody likes to vomit. But also if our patient is still not completely awake yet, they could vomit and be at risk for aspiration. So we do want to control nausea and vomiting for comfort as well as to prevent further complications. There are a few ways we can do this. We can, I mentioned odors. We can keep, the meatloaf away from them in that post-operative period, or White Castle or whatever. We can provide antiemetics per the provider's order. So things like ondansetron, also known as Zofran, that's commonly used in post-operative nausea. Another drug we use sometimes is promethazine, also known as Phenergan. It works really well. It can contribute to drowsiness and decreased respiration, so we have to be careful giving that one. Oftentimes patients like it because it does kind of relax them a little bit. It helps and it does work well for nausea, but just know it can also affect the level of consciousness and respiratory status of the patient. But that's a good antiemetic. There's aromatherapy that we can use at the hospital here. We have this little product, it's called, Queasies or something like that, and it's an inhaled, just like smell that's supposed to be calming to the stomach. Patients seem to like it. It smells pretty pleasant. I don't know what's in it, peppermint or something like that. Lavender, maybe. I don't know. I'd have to look at one of the packages to see what kind of actual ingredients are in it, but it's a pleasant smell. It's supposed to calm the stomach, help with nausea. Something else to consider when a patient's experiencing nausea and vomiting is that, do we really want to feed them? Remember, our patients have been NPO for surgery, likely for a period of time. They're feeling hungry, and yet they're nauseated. I have a couple of different thoughts on this. Number one, sometimes people feel really nauseated when their stomach is empty. So trying to completely withhold food if they're allowed to eat may not always be the best answer for that. We talked in the preoperative video about slowly advancing a diet in the postoperative period. So this might be a time where maybe we give the patient has an order to advanced diet as tolerated. We give a little bit of water or Sprite maybe. Sometimes people find that carbonation a little settling to their stomach. Let that sit for a little bit. If they're tolerating that, fine. Maybe a cracker. I mean, you know, whose mom didn't offer them a cracker when they were sick to their stomach and staying home from school? Now you have to be careful because you have to have the diet orders in place to be able to do that. Some of our patients who you know, we don't want to put anything into their stomachs because we don't want to have their guts work. Maybe they've had an extensive surgery. We have to be careful with that. And in that case, we might not be able to use that intervention, but, you know, interventions are individualized to the needs of the patient and the situation that we're dealing with. So that side of it is maybe offering a little bit of something to put in their stomach might make them feel less nauseated. The other side of that is the question of, if we put stuff in their stomach, is it going to make them vomit? We're always going to have those patients, my husband being one of them. And I think I mentioned this before in the pre-op video. When he woke up from surgery, he was so hungry. He really wanted to eat all of this food, but he wasn't feeling nauseated until he ate. And part of that was because he drank like 2 snack bottles of grape juice and inhaled a bunch of crackers. And then by the time he got home, with the moving and the vertigo and the driving and all of that, he was hurling everywhere. I wasn't surprised, but I was a little bit annoyed. You know, when patients get this medication that makes them, you know, go to sleep for surgery, that inhibition sometimes is depressed. That's why you see all those funny videos about people after having, you know, their wisdom teeth pulled out, because we lose that inhibition. So people are going to ask for stuff and you're going to be like, no, you can't have that. And they're going to keep asking, they're going to keep forgetting. So we have to look out for our patients, what's best for them. So maybe try a little bit of something, see if that makes them feel better, but don't let them go to town on the meatloaf, because it's not going to be a pleasant feeling later. Let's see, if a patient has excessive vomiting, especially if they've had abdominal surgery, that can put them at risk for dehiscence or evisceration, which we'll talk about later, because it's going to increase the intra-abdominal pressure and put stress on that suture line. If the vomiting is uncontrolled, they may have a nasogastric tube in place to control those gastric contents and to decompress the stomach and allow the intestines to rest. So that might be something else to consider if the vomiting doesn't get better. Again, it's very much a possibility that if your patient did have a large abdominal surgery, that they already have an NG tube in place, and we're going to be monitoring that output. We'll talk a little bit more about that when we get down to drains. I think I have a place about that. So different things we can do there for nausea and vomiting, but it definitely is an expected finding in the post-op period. I do want to mention something about promethazine. It just came to mind when I was talking about that medication. Promethazine is, as I said, a really good drug. It's often administered IV. We don't want to give promethazine IV push. It's just like draw it up in a syringe and push it through the IV. We used to, but the risk of it infiltrating or extravasating into the tissue around it at that concentration is really is dangerous and can lead to tissue death and necrosis. And so when we administer promethazine, it's now being given over about, I don't know, 15 or 20 minutes, I forget, as a secondary or piggyback infusion, just to dilute that medication a little bit more. And we need to monitor that IV site while administering it. Because if the patient starts to have signs of infiltration, we need to stop it immediately. And there's like a antidote or something that we inject into the site, the tissue around it, to kind of inactivate the medication. So we gotta be careful with that. So an ileus, what is an ileus? This is just like a paralyzed portion of the intestine. Our intestines are constantly moving. We have that thing called peristalsis. That's just what our intestines do. And after surgery, in response to anesthesia, number one, anesthesia and opioids can slow down peristalsis, which can lead to like a paralyzed or lazy gut. So everything just kind of backs up and just sits there. We're not having any movement of anything through the intestines, which can lead to nausea and vomiting. It can lead to abdominal distension and pain, and just generalized discomfort. Another reason a patient might develop an ileus is if they've had a large abdominal surgery. Let's say they've had, I don't know, something's wrong with their intestines. When they go in and they do the surgery and they open up the abdominal cavity, they don't work within this little hole on a portion of the intestine. They'll take out the intestines from the abdominal cavity and work with them sometimes in that fashion. Maybe they're running it. They're kind of like checking each piece, the whole entire length, I guess, of the intestine to make sure there are no abnormalities. And then they kind of put it all back in there. Imagine for a moment, if you will, that you are a portion of an intestine and you're nice and comfy cozy in your little cave, and all of a sudden you get ripped out of your home, exposed to all this weird random stuff, get fondled, and then get shoved back in your house, right? You might be a little bit traumatized, a little PTSD, and so you're just going to kind of sit there and not do anything because God knows it might happen again. At least that's what you're thinking as an intestine, right? So sometimes it can be a little slow to kind of wake up after surgery if it's been manipulated quite a bit. So part of our assessment of our patient, again, I said it can cause nausea and vomiting, abdominal distension, but also absence of bowel sounds and no presence of flatus. We're always asking our postoperative patients, have you been passing any gas? Because that tells us whether or not the intestines are having a return of peristalsis. Now, it's completely expected when a patient comes out of surgery that their bowel sounds would be hypoactive. Very expected. They've had anesthesia. If they've had an abdominal surgery, there's been some manual manipulation there of that organs. So they're going to be slow to wake up. But if it's been a couple of days and the patient's not having any evidence that the intestines are working, not expecting them to drop a big deuce or anything, but passing gas at least, and good, and normal bowel sounds, we have to start being concerned about the potential for an ileus. Things that we can do to help prevent this: walking, honestly, is one of the best things we can do. Walking just helps to encourage peristalsis and stimulation of the intestines. So always walking, ambulating in the hallways, moving, getting up. We got to prevent our patients from laying around in bed. You'll find as we go through this PowerPoint that walking is pretty much a cure-all for a lot of things. So we need to be encouraging our patients to get up and move. We're meant to move. So yeah, ileus is something we can try to prevent with ambulation. If a patient does develop an ileus, we're going to end up restricting their diet. So if we had been advancing their diet and they were eating, they're probably feeling miserable because stuff's not moving. But we're going to likely back up on their diet. We may try to just do conservative management and just get them up and walk them, back off on their diet, increase their IV fluids, control their nausea and vomiting. But if they're very distended, if they're starting to have a lot of vomiting, it's because contents are backing up into their stomach because they're not able to go forward because that part of the intestines are paralyzed. And so they might then get a nasogastric tube to help with just to suck out everything from the stomach and to decompress. So if we decompress the intestines and we keep stuff from actually going through the intestines, and we give them time to kind of wake back up on their own and allow them to rest and warm back up without stressing them through putting food and other things through them, making them work. So it's kind of really all I have to say about an ileus. At some point during your education, you'll probably talk about a small bowel obstruction. We see those. It's a pretty common med-surg diagnosis, actually, and it's kind of the same sort of thing, maybe a different reason. Maybe they have some kind of other thing that's leading to a lack of movement within the intestine, but for postoperative, ileus is what's leading to that lack of movement in the intestines and thus the backup of contents. Constipation can occur postoperatively, primarily because of opioids that we're giving for pain, but also because of the medication that we gave during surgery, the decreased movement, the change in diet, right? Patients who are postoperative aren't drinking as much fluid, which we need to help prevent constipation. And they probably aren't getting as much fiber as they were before to help prevent constipation. So those are just normal things that we can do. There might also be a fear of defecating, especially if they've had abdominal surgeries or things like that. Whether it's conscious or unconscious, people are afraid that they're going to have discomfort. So we need to make sure we're giving our patients plenty of fluid as they're able to tolerate and allowed to have plenty of fiber in their diet. If we have to, we can give stool softeners and things like that. We don't really like to give stimulant laxatives necessarily to a patient, especially if they've had a bowel surgery, because that can kind of jack with things down there. But things like Colace and seem to be pretty common. Miralax, sometimes I see that given. Enemas, usually not so much. Again, if they've had some kind of bowel surgery, we don't like to increase the pressure in the intestines in that way. But walking, again, is a really great thing to help with constipation. It encourages peristalsis. So that's the GI stuff. Let's see what we got next here. Pain. So we have talked a little bit about pain in preoperative lecture. Remember something, I don't know why this is a pet peeve to me, but just something to remember. We rate our pain on a scale from 0 to 10, not 1 to 10. If we say 1 to 10, then that's communicating to our patients that there is no likelihood ever that no pain can exist, right? And that's not true. I have 0 pain right now, right? So why would I rate it a 1 if I have no pain? So anyway, off my soapbox. So we rate pain on a scale from 0 to 10. 0 means I'm not having any symptoms of pain or discomfort whatsoever. And 10 is up there on that severe end of the symptoms. You can see the Wong-Baker Faces scale on here that's typically used for pediatrics. I'm not going to go into that just because this is not a pediatrics class. I would like to point one thing out to you though. You'll notice that on the number 10's frowny face that it has tears. One thing to consider if you're having to use a scale like this for someone who maybe isn't able to quantify their pain using a number, sometimes we'll use this with adults also, is that you don't have to be crying to have a pain that you rate out of a 10. So that's just something to think about. So a pain rating is very personal. It really is all up to the patient. We give them a visual like this to help them pick a number. But what I consider mild pain and what you consider mild pain could be very different. So a 2 to me may be very different, and what I need to deal with a 2 may be very different than what a 2 is to you and what you need to deal with a 2. We can have physical signs of pain. We can have tachycardia, increase in blood pressure, increase in respiratory rate. We can see restlessness. We can see moaning and groaning. It really just depends on the person. But again, someone who's experiencing very severe pain may not have those physical changes. So we can't rely solely on physical changes. We also have to rely on that subjective number that a patient actually tells us. That's kind of a frustrating thing about pain, especially if you're dealing with someone who you're not really sure that they're experiencing pain. They don't seem to be having any reason to experience pain. But at the same time, if you are a patient who is truly experiencing pain and you're not having those physical symptoms, you can sometimes get the impression that people don't believe you. So pain is a tricky subject. We'll kind of stay back on topic here. With surgical patients, we are anticipating them to have pain. I do tell my patients, someone's getting ready to cut you open with a knife, you're gonna have pain. So it's not a matter of a realistic and tolerable level of pain being a 0. You need to pick a number that you feel like I can get up and move. Patients need to be able to participate in recovery and therapy, and that's the level that we want their pain controlled at. If they're in so much pain that they can't get up out of bed and move, then that's a problem. We need to lower their pain. They need to be getting up. They need to get in a chair. They need to ambulate. They need to walk to the bathroom, whatever they can do to help them get back to the baseline. So a couple of things that happen is I have older people say, I don't want to take pain medicine because I don't want to get addicted. Well, that's great. You're probably not going to get addicted to pain medicine in the short couple of weeks that you might be needing pain medicine. So something to kind of educate them about. Also, if your pain is not controlled and you therefore refuse to get up out of bed because it hurts too much for you, then that's impeding your therapy. So pain medication is kind of necessary. So we want to make sure we educate patients about that. Let's see, tolerable pain level, again, 0 is usually unrealistic for a post-operative patient. So they need to pick something, again, that they can do whatever they need to do during the day and get around. It doesn't matter what number they pick. They just need to understand that that's their goal. That's where they're going to live while they're in that recovery period. When we give pain medication or we implement pain reducing interventions, if they're working, the number should go down. So that's another problem that patients often have. They're like, oh, I don't know, it's so hard to rate my pain. Just pick a number. I don't care. We can always adjust it later. Let's just start somewhere, okay? If you rate your pain at a 6, and I give you pain medicine and your pain is better than what it was before, then when I ask you what your pain number is, it shouldn't still be a 6, right? Theoretically, it should go down because it's better. It also shouldn't go up if your pain is better. So some education is required. We can give pain medications. We like to use opioid medications like hydromorphone, which is the infamous Dilaudid. Morphine is another one. Fentanyl is a very potent one. Let's see, non-narcotic or non-opioid pain medications. Ketorolac, also known as Toradol, is really good pain medicine for kidney stones. It's an NSAID. I don't know, there's a bunch of pain medications. Those are all IV medications. Now, patients can take oral pain medications after surgery too, things like hydrocodone and oxycodone. And those are mixed with Tylenol. They're called Norco and Percocet, respectively. So those are good medications. Tylenol, I mean, good old Tylenol is wonderful for pain control, especially in our older patients. It has less of those side effects. I just had a message pop up on my screen that my AirPods were going to connect, which is so weird because they're like all the way on the other side of the house. So if you lost me, sorry about that. I think I disconnected them. Okay, pain. What was I saying about pain? Tylenol works really well for our older individuals. Don't be afraid to use Tylenol for people for pain. It's completely a legitimate drug. Sometimes people think because it's over the counter that it's not effective, but it really is, and it doesn't have all those side effects that increase the risk for falling, things like dizziness and lightheadedness and that kind of thing, nor does it have the side effect of respiratory depression like our opioid medications do. Anytime we give a pain medication, We need to reassess after the administration of that pain medication because we want to know if it's working. If your pain is a 6 and I'm giving you a milligram of Dilaudid every 15 minutes and it's not working, why am I going to continue to give you that medication? It's not working. Let me give you something else. Let's try something different. There are other things that we can do for pain. We don't just have to push drugs on people. We can implement other interventions, things like repositioning, distraction, turn the TV on, get a puzzle book, have family visits. Sometimes those things can help. We can use ice or heat, whatever is appropriate for pain control for that patient. Getting up and walking. There's lots of things, different things that we can do for pain, meditation, relaxation techniques. There's all different kinds of things. It's just whatever works for your patient. You can always try things. So if a patient's really using a lot of pain medicine, we need to encourage them to try other pain relief measures. So they're not just getting bogged down with pain medicine. Let's see if there's anything else I want to say about pain. Thinking for a second. I don't think so. I think that's good enough. Let's go on. Okay, cardiovascular assessment. We know that this is going to include things like blood pressure, heart rate, and signs of perfusion. I guess that's primarily what we're looking for when we're doing a cardiovascular assessment. So we're listening to heart sounds, we're checking a patient's blood pressure, we're checking their heart rate, listening and checking for the regularity and quality and all of that kind of thing. Perfusion, remember this has to do with the blood getting to where it needs to go and that it's circulating and moving everywhere like it's supposed to. So capillary refill and pulses and things like that, that's all part of your cardiovascular assessment. Color is even part of cardiovascular assessment. So a couple of complications that can occur within this kind of body system, blood clotting. Number one, we kind of have blood clotting and not enough blood clotting, right? So first of all, we have blood clotting issues. So we can at risk for DVT. DVT stands for deep vein thrombosis, which is a blood clot in the deep veins of the legs. This occurs because the patient is immobilized for a prolonged period of time. When a patient is in surgery, they are just lying there completely paralyzed. They're not moving. Even when you are in bed asleep, dead to the world, right? Sleeping, your body still moves, but not when you're in surgery. It's a completely different kind of paralysis. You're not moving at all. When that blood in the lower extremities, especially, right? The lower extremities have to work to get back to the central circulation. The blood down there does. When that blood just sits there in the lower extremities, it can pool. And if you think about a time you've ever gotten a cut on your finger, if you've just sat there and kind of watched it ooze and then it kind of starts to stop oozing because it's starting to clot there, right? Or you've had a nosebleed and it kind of pools in your nose when you've pushed on it, right? And it starts to clot. Well, that can happen as blood pools, it clots. And if I have a clot that develops in a vessel in the deep vessels of my leg, then more platelets want to stick to it and the clot can get bigger and bigger. So that's what's happening with a DVT. Now, normally, like you and I are up, we're walking around, we're moving, our muscles in our legs are encouraging the blood from in our legs to be pushed back up to the central circulation. This is why when you go on long car trips or you go on long plane rides, it's encouraged that you get out, you walk around every couple of hours, you get up, you walk up and down the aisle, you wear compression socks, because that blood is pooling in that dependent position. It has to work against gravity to get back up to central circulation. Same kind of concept there. So our surgical patients are at increased risk for DVT because of that prolonged immobilization. So what do we do about that? Well, we are going to encourage early ambulation, because ambulation causes the muscles in the legs to contract and therefore push the blood back up to the central circulation, so it's not pooling. Secondly, we're going to administer DVT prophylactic anticoagulants. So what that means is we're giving an anticoagulant medication that's going to prevent these blood clots in the legs. Primarily two medications that we use for this. The first one is heparin. It's a subcutaneous injection. It's been around for quite some time. It's relatively cheap and inexpensive. The patient typically has to have an injection every 8 to 12 hours. So they're going to get a shot 2 to 3 times a day. The half-life of this drug is pretty short. It's nothing they're going to go home on. It's strictly for something prophylactic while they are in the hospital. So it's just a short period of time. It just is going to prevent the blood from clotting. Another medication that we will see prescribed for DVT prophylaxis is enoxaparin, also known as Lovenox. This is a low molecular weight heparin, so it's like heparin but different. A nice thing about this drug is it's typically once a day, although sometimes people will take it twice a day, but for DVT prophylaxis, it's usually once a day. It is a subcutaneous injection. It can only be given in the abdomen. It cannot be given anywhere else. But it's more expensive, so it's really just up to the surgeon on what they want to order for their particular patient. I see both. I tend to see runs. It'll be like, for a while everybody's on heparin, and then the next thing I know, everybody's on Lovenox. So I don't know why they choose what they choose. I asked a provider one time, and I got the answer, essentially what I just told you. It just kind of depends on how the doctor feels. So we give this anticoagulant medication. Now, if I am giving a medication that's going to prevent my patient from clotting, then I also have to monitor for the side effect of bleeding. So making sure that my patient's platelets are good when I look at their blood profiles, making sure they don't have evidence of excessive bleeding, like excessive bruising, bleeding of the gums, blood in the urine, blood in the stool, things like that. So I want to keep an eye on too much coagulation too, right, when I give a medication such as that. Another thing I'm going to do for DVT prophylaxis is SCDs or TED-HOs. I'm not seeing TED-HOs quite as much as I used to in the hospital. I do still see them sometimes. But for the most part, we really like to put SCDs on our patient. And I showed a picture of that at the preoperative lecture. It's these little sleeves that wrap around the calves, and they attach to a pump. SCD stands for Sequential Compression Device. And what that gadget is doing is sequentially compressing the muscles in the legs so that it's mimicking what the muscles in the legs do when they walk, and it kind of helps squeeze the blood back up into the central circulation and thus prevents DVT. So walking, SCDs, and pharmacological intervention is how we work to prevent DVT in our patient. It's very important that we educate our patients about that. Because a lot of times they don't want to get the shots. They get scared by the word blood thinner. They don't like the sleeves on their legs. They do put the patients at risk for fall because it kind of attaches them to the bed. So we do have to be careful of that, make sure we're disconnecting them. Or they don't want to get up and ambulate. So we put these things in place to prevent complications, and then patients are resistant to doing them because they're uncomfortable or they don't like it. So a lot of education about why we're doing what we're doing and how it helps the patient in their recovery process is required. I'm going to jump down to PE, which stands for pulmonary embolism. Kind of goes hand in hand with DVT, and for the most part, our interventions are the same. Oh, how do you know a patient has a DVT? I guess I should go back and say that. DVT is going to look like pain in the calf. You're going to have redness and warmth from that extremity. You're going to have potential evidence of decreased perfusion, so maybe a decreased pulse in that extremity. It typically doesn't happen bilaterally. It's going to be one leg or the other. There might be redness, if I didn't already say that, an increased circumference in one compared to another. So if you suspect that a patient has a DVT, you would want to alert the provider immediately. They might have, like I said, pain and stuff in that leg, swelling. They're going to get what's called a venous Doppler, which essentially is an ultrasound of the blood vessels in the leg, and they're going to visually look for clots. If a patient actually has a DVT, then the treatment for DVT is a blood thinner, and not just while they're in the hospital. If they develop a DVT because, let's say they didn't want to follow treatment, or the nurse is not putting on the SCDs like they're supposed to, or, whatever. If they develop a DVT, now they're going to have to go on anticoagulants long term. And it's not going to be just a heparin injection or a Lovenox injection while they're in the hospital. They're going to get started on something orally, most likely, that they're going to have to go home on for a long period of time. And so it increases their risk of bleeding, like unintentional bleeding. Plus, it's a new medication for them. It's a new lifestyle they have to deal with because they're being placed on anticoagulants. If a patient gets a blood clot in the leg, they don't typically go in and do a clot evacuation. If it's completely occluding the vessel and leading to perfusion issues, then yeah, maybe. But for the most part, we're going to give the patient anticoagulants, which is going to help prevent the clot from getting bigger, or any more new clots from developing. And then the body is just going to get rid of that clot on its own in time. So prevention of DVT is going to be really beneficial for our patients in the long run, because if they do develop a clot, then it's going to be, something they're going to have to manage at home for a long time. Okay, so now I can move on to pulmonary embolism. Is a clot in the vessels that go to the lungs. Okay. Most often it occurs because the patient has a DVT and it's gone undetected long enough to the point where it's broken off, and that clot has traveled up into the pulmonary vasculature. And so we have part of the lungs are being blocked off by a clot. So you can imagine, if my lungs aren't getting the blood flow that they need, my patient's going to feel short of breath, tachycardic, hypotensive. My brain is totally farting right now on all the signs and symptoms of PE. So give me just a second here. I'll move on. Treatment for PE. So we don't really do PE prophylaxis other than DVT prophylaxis. But treatment for a PE is the same as treatment for DVT. So we're going to have to give them anticoagulants for a long period of time. Okay, signs and symptoms of pulmonary embolism. Sorry about that. So chest pain, and especially with breathing, patient might have hypoxia. I guess you can imagine that, because we're having decreased capability of oxygenation there. Tachycardia or palpitation, so feeling like your heart's kind of skipping a beat. Increased respiratory rate, feelings of shortness of breath. You might also have a cough. Hypotension can occur. Sometimes patients will have a feeling of impending doom. That's never, that is never something to mess around with. If people tell you, I feel like I'm going to die, that's like a real symptom of something. Dizziness can occur. I think those are the big ones. So that's how you know a patient might have a PE. So if you think a patient has a PE, you might want to call the provider, let them know. They can order a series of tests. The first one they do will probably be a blood test called a D-dimer. If that comes back elevated, that's an indication that it might be a pulmonary embolism. You don't need to know ranges for that. Just know that an elevated D dimer could indicate a pulmonary embolus. If that comes back elevated, they might send the patient for a CAT scan of the chest, or what's called a VQ scan of the chest, or a ventilation perfusion scan of the chest, just to confirm that there is a pulmonary embolus. But again, treatment for that is going to be the same as treatment for a DVT. We have to coagulate the blood so that it doesn't get any bigger, and continue to monitor patients' respiratory status. Now, this development of a PE is going to prolong their stay. Remember, ABCs are pretty important. A patient might even require oxygen, right? Because they're not able to get the oxygen that they need in their blood because the blood's being okay, so the other side of this is hemorrhaging. Hemorrhaging is losing blood. We can see visible signs of bleeding, whether it's through an incision or a drain of some sort, more than what would be expected. We may not see signs of bleeding. Perhaps the patient is bleeding internally, so we're not going to be able to see that. I don't have x-ray eyes yet. And I don't think you do either. We haven't mutated that much. But anyway, we need to be able to understand what a patient is going to present like if they're bleeding in ways in which we can't see. So when a patient is hemorrhaging, if you can actually hemorrhage into your abdomen, your chest, or your pelvis without any visible signs of bleeding. There's enough space in those anatomical locations for a person to bleed out into. So we can look for things like abdominal distension, blood in the urine, muffled lung and heart sounds, right? That might be an indicator because those spaces are filling up with blood, right? So I've never seen. I've seen it once. I've seen someone bleed into their abdomen before, but I don't see that very often. In 15 years, once is not too bad. But physical symptoms of hemorrhage are those signs of low blood volume, right? So we've talked about hypovolemia. We've talked about what that looks like in our patients when they have hypotension, tachycardia, because they're trying to compensate for that low blood pressure. We might see changes in level of consciousness because they're not getting enough blood and oxygen. We could see hypoxia. We could see pallor in the skin. We might look at our blood profile and see that our hemoglobin has dropped quite a bit. So if we're seeing those types of systemic signs of blood loss, then we need to be alerting the provider to that and checking our blood counts and looking for signs of bleeding. It might take a minute for blood counts to get caught up with what's actually happening in the body. I had a patient one time that a patient was bleeding into their abdomen. When we moved, first of all, it was not a surgical patient, but this is a good example of how it takes a minute for things to catch up. We had a patient who was having rectal bleeding, and they were stooling pure blood. And when you would turn them over, blood would squirt out of their rectum, and you could feel the blood sloshing in the abdomen. I've never seen anything like it before. We had contacted the provider. The provider came to see the patient. They wanted us to draw blood on the patient. So we did, of course. They wanted to see a hemoglobin, but this patient was bleeding profusely. Now the hemoglobin came back at, I think it was like 7, which is low. I'm not going to say it's not low. It's low. I think normal is like 12, 14, 15, something like that. But this patient came back at 7. And I'm telling you, when I say this patient was bleeding profusely, I mean that this patient was bleeding so much as they were stooling from their rectum that the blood was dripping off the bottom of the bed onto the floor as we were cleaning them up because it just kept coming out. So when we got them to critical care, that result came back and the hemoglobin said 7. And the provider was like, oh, see, they're fine. Now, I mean, I get what they're saying. Sometimes what we think is a lot of blood really isn't a lot of blood. But the nurses were very persistent there on that unit that had received that patient. And they were really persistent about rechecking those lab values. And when they did, not 15 minutes later, 20 minutes later, that hemoglobin then on their blood profile had dropped to 4. That's a huge drop from 7 to 4 in such a short period of time. So that's just an example of how sometimes it can take a little bit for things to kind of catch up in the body before you can actually see them. So don't ignore those signs and symptoms that you're seeing. And again, that gut feeling, we kind of talked about that when we talked about vigilance earlier in the semester. So yeah, what are we going to do about hemorrhage? I guess that's what can cause hemorrhage? First of all, sometimes we just don't know. I mean, we're going in there cutting things up in the body. If an artery or a vessel gets nicked or it doesn't get cauterized completely, it can lead to bleeding. Maybe a patient sneezes or something just dislodges in there, a patient can start bleeding. As far as what we're going to do about hemorrhages, we need to worry about ABCs, right? We have to put the volume back in, and that could just simply be just fluids like normal saline. Now, depending on how low or how extensive the hemorrhaging or bleeding is going to dictate what the provider is going to be ordering. But maybe it's just going to be a little bit of fluid. We might replace blood loss and give blood products like packed red blood cells. If the patient is really in need of volume and we can't get blood in them fast enough, there might be other volume expanders like dextran. And they might even have to go back into surgery if they're continuing to show signs of hemorrhaging and they're systemically they're crashing. They might have to go back into surgery, open the patient back up, and visually inspect for where that bleeding is occurring. All right, I think we've made it through that. Respiratory assessment. We've talked a little bit about airway breathing when we mentioned pulmonary embolism, but there are other problems that can occur in airway breathing after surgery. So we intubate a patient during surgery, whether that's with an advanced airway such as an endotracheal tube where the tube goes all the way down into the trachea, right, and ventilates then the lungs. We take over that breathing task because we're paralyzing and sedating the patient, or we put in what's called a laryngeal mask airway or something similar where it just kind of goes in above the trachea, but it still is going to ventilate the patient, take over that breathing. And the medications that we give during surgery just kind of slow down and depress everything, right? So because of what we're doing to the body, because the patient's having pain and the patient may be getting pain medications, they're not taking nice deep breaths, they're not breathing as much as quickly as they should, the lungs can get kind of lazy, I guess. When you take a nice deep breath and then let that deep breath out, right, that deep breathing opens up those alveoli down there, way deep down in the lung, and that's where gas exchange takes place. Oxygen and carbon dioxide, right, that gas exchange takes place in those alveoli. And those deep breaths, they kind of pop those alveoli open, and the more alveoli that are popped open and nice and big and they look like little grape clusters, the more surface area there is for gas exchange. Now, when my breathing is depressed because I'm taking opioids or because I've just had surgery, those alveoli get collapsed down on one another. And when they collapse down on one another like that, it allows for fluid to kind of come into that space. Fluid in and of itself may not necessarily be bad unless bacteria infiltrates that fluid. So I'm kind of working on a few different things here. When those alveoli are collapsed, now I have a decreased surface area for gas exchange, which means I'm not going to be oxygenated as much as what I would be if those alveoli were popped open. So atelectasis is when those alveoli collapse. right? And I don't see as much space. I don't have as much space for gas exchange. There isn't really any fluid or any kind of infectious process going on. We just have that collapse, that decreased amount of lung opening space. So to help with atelectasis, and this happens because the patient's not breathing like they're supposed to. They're not deep breathing. They're not having that good ventilation and respirations like they normally would. So what we're going to do to prevent this is we're going to encourage the patient to cough and deep breathe, to use an incentive spirometer, which is basically an exercise machine for their lungs that gives them a visual goal to take nice deep breaths and then let those breaths out. That encourages popping open of those alveoli. As you cough, deep breathe, send a spirometer. Oh, and guess what? Walk. Sitting up and walking, because that allows for greater expansion of the lungs. So those are the things we're going to do to help treat atelectasis as well as prevent atelectasis from occurring and potentially causing other problems. If a patient has atelectasis, they're likely to have signs of decreased gas exchange. So things like low oxygen level. Good, normal, healthy patients should have a SpO2 of like greater than 95%. So if you have a patient who is 20 and their O2 level is 90%, well, acceptable, it's not adequate. They probably have some atelectasis going on, and they need to be doing those interventions that I mentioned. Now, a patient can also develop pneumonia if those alveoli stay collapsed and fluid is allowed to get into that space and it becomes infected with bacteria. And that can happen just by breathing because we have bacteria in our mouth, right? So good oral care is the first thing that we can do to help prevent pneumonia. Secondly, the same thing as atelectasis, right? If we prevent that from those alveoli from collapsing, then that fluid's never going to even get in there in the first place. So again, coughing, deep breathing, incentive spirometry, walking. But as far as what our patient is going to look like, this is an infectious process. So we're going to see a change in their temperature. We're going to hear that fluid in the lungs, and fluid starts at the bases. So when we hear that fluid in the lungs or that diminished breath sound because there's no air movement going in there, we're going to hear crackles and diminished sounds. It's not going to be nice and aerated like we would expect. We're going to see tachycardia. We're going to potentially, depending on how bad it is, we're going to see tachypnea. We're going to see hypoxia, an increased need for oxygen, right? So that's how we know patient has pneumonia. If your patient, if you're doing your rounds in the middle of the night, your patient is a post-operative patient, you check their temperature and it's 101.6. Well, you need to call the doctor because there could be an infectious process going on, and they'll probably get a chest x-ray to verify if it's pneumonia or not. Again, the interventions for that are going to be antibiotics if it's a bacterial pneumonia, of course, and then coughing, deep breathing, that kind of thing. The whole coughing, deep breathing thing can be really difficult for patients simply because it's when we deep breathe and cough, it's going to stretch the tissue. If you think about the types of surgeries that patients commonly have, abdominal surgeries, maybe a chest surgery, stretching that tissue is going to be painful. And so patients aren't going to want to take deep breaths. They're not going to want to cough. And that's why this is such a prominent problem. So we have to encourage them to kind of work through the pain. Another reason why we encourage control of pain. Splinting is another technique we can do to help patients to decrease their pain, to decrease the risk of dehiscence and evisceration by supporting those incision lines while they're increasing the pressure in the abdomen and chest cavities. And simply all that is it's kind of like giving yourself a little hug. You can do that with your own arms and kind of support externally that incision. You can do that with a pillow. We teach patients that to kind of hold a pillow over their incision site, kind of provides extra external support. So when they're deep breathing and they're coughing, it's not just pulling, we're putting that external support on that incision line as well. Respiratory failure, greatest risk for patients postoperatively is within the first 72 hours. This is just something that we're constantly monitoring our patients for through doing our respiratory assessments, listening to lung sounds, watching respiratory rate, watching SpO2. If a patient is on a narcotic pain medication, especially like a PCA where they have that on-demand push button action that they can do, we might be monitoring their end-tidal CO2. End-tidal CO2 tells me whether or not they're blowing out enough carbon dioxide. That's part of that gas exchange factor that happens in the lungs, right? We want our oxygen level to be good, but we also need to have a normal amount of carbon dioxide. Normal amount, I think, is 35 to 45. So if we're too much or too little, we could be hypo or hyperventilating, meaning we're blowing off too much CO2 or we're not blowing off enough. A patient who's retaining CO2 actually can sometimes present, well, first of all, if they're retaining CO2, they're not breathing deep enough and out enough, right? Their respirations are too shallow, so they're not able to blow off that CO2. So we have a hypoventilation issue or a shallow breathing issue. But as that CO2 builds up in the bloodstream, starts to lead to acidosis, and it can really affect neurological status. Patients can become confused. Patients can become restless. They can have a decreased level of consciousness. So I didn't really have a specific neurological assessment here in this lecture, just because neurologic assessment can be a manifestation, or neurologic issues can be a manifestation of other things. For example, respiratory problems. There are so many links here. It's just incredible. So if I think about my patient who's hypoventilating, in other words, they're taking very shallow breaths, it could be because of pain. Their pain is not controlled well enough. And so they're not taking those normal breaths like they should be. So I need to make sure I control my pain. It could be because of pain medication. Perhaps I've over-medicated my patient, not intentionally, of course, right? But we know that opioid pain medications can decrease respiratory rate. So perhaps it could be too much pain medication. So my patient's not taking those nice, deep, shallow breaths, or even just normal breaths. Nice, deep, shallow breaths. What does that even mean? That's not what I meant to say. Patients not taking nice, deep breaths, rather they're taking shallow breaths because of too much pain medicine in their system. Can lead to that buildup of CO2. So we might see neurologic changes. Perhaps what we need to do is reverse the opioid, which would be a dose of Narcan, right? We don't really want to give Narcan if we don't have to, just because now I have blocked all the opioid or mu receptors in the body. And it doesn't matter how many opioids I give until they wear off, my patient's not gonna have any pain relief. So we don't like to give opioids, so just carefully monitor your patient and be careful with that pain medication. So kind of show that link there to you between respiratory, pain, neurologic assessment. So just something to think about. I think that's pretty much all I want to say about respiratory issues. Let's see what else we got here. Fluid and electrolyte balance. Oh, everybody's favorite. We've talked about hypovolemia in terms of hemorrhage. We can also just have a regular old hypovolemia without active hemorrhaging. Patients do have blood loss during surgery. They may get a little bit dry, and that's going to lead to decreased perfusion. If we don't have enough volume in the vessels, then we're not getting blood perfused everywhere it needs to go. So again, that hypovolemic patient is going to look a little bit dry, and they're going to have a low blood pressure. They're going to have tachycardia for compensation, and they're going to have signs of decreased perfusion. One way to really monitor signs of hypovolemia and that evidence of decreased perfusion is urinary output. If a patient's urinary output is low, we might need to consider that their kidneys are not getting adequate perfusion. So our kidneys filter the blood, and the filtrate that comes off of that is how we produce urine. So if the body's trying to hold on to extra volume, then we're going to have decreased urinary output because the body needs all that volume that it can have to maintain homeostasis. So urinary output, that's one reason why we monitor that and how it relates to that volume state. Another thing we might look at is BUN and creatinine. That's going to tell us if the kidneys are working as well. What can we do if a patient is hypovolemic? Well, we can give them some fluids. It's probably the first thing we're going to do. And we're going to monitor for an increase in blood pressure, a decrease in heart rate, and an increase in urinary output, right? If we have a volume issue and we're replacing the volume, we would want to see an improvement in the things that told us that they had a low volume. On the other side of that, we could also see hypervolemia, which is going to be too much volume. And that can happen just because of all of the extra volume that a patient received during surgery or that we're giving post-operatively. So if you recall back to our fluid volume lecture, hypervolemia is going to present as tachycardia, hypertension. Perhaps there's some edema going on. We might have a change in heart sounds, a change in lung sounds with crackles present because of all of that volume. Which would lead to tachypnea, hypoxia, a cough that sounds wet but is not productive. So those are all signs of hypervolemia, shortness of breath. What do we do about hypervolemia? Well, we need to get the volume off of there. So we're going to stop any fluids, and we're probably going to give a dose of diuretic like a furosemide/Lasix type of thing there. Patients who are at higher risk for hypervolemia are going to be those patients who already have volume control issues, whether they're patients who have renal dysfunction or cardiac issues like congestive heart failure or history of MI, and in older patients. So we need to be monitoring those people very closely, especially if they're getting continuous IV fluids after surgery. Urinary retention can occur. So this is just a functional issue with the bladder, not a systemic issue with the kidneys not getting perfused. So if my patient has had surgery, the anesthetics, the opioid pain medications can actually lead to a lazy bladder, and we're not urinating. It doesn't mean that the body's not making urine. It is making urine. It's just not coming out of the bladder. So after surgery, we give our patients about 8 hours to urinate. They may not even have the sensation that they need to urinate, especially if they're just laying in bed, not moving around. So it's always a good idea to just get the patient up and sit them on the potty and just say, give it a go. Let's see what can happen. Sometimes that does the trick and they go and they're like, I didn't even know I had to pee. That's typical. Sometimes we get them up and they just really can't go. But once it gets close, like gets to that 8 hour mark, we really need to be making sure that number one, the kidneys are working. And so we want to rule out that it's not a retention issue. And so we can do a bladder scan. Bladder scan is a non-invasive, like little ultrasound that can tell us how much volume is in the bladder. If we see that we do a bladder scan and we see that there's nothing in the bladder, then it might be a perfusion issue. But if we see that there is, 400 or 500 milliliters of urine in the bladder, then bladder is just not emptying that out. Some places will have a urinary protocol of sorts where if you do a bladder scan and the bladder scan results are greater than X, whatever that facility indicates is the cutoff, then you can do an in and out catheterization. So this is a sterile procedure that you've learned, but it's not going to stay in. It's not an indwelling urinary catheter. It's just an in and out catheterization. So we get a kit, we open it up using sterile technique. We put the catheter into the bladder, drain the bladder, take the catheter right back out. Ideally, when we do a bladder scan, if it tells us there's about 400 milliliters in the bladder, when we do an in and out catheter, we should see about 400 milliliters come out. Once we've done that, the patient now, their timer starts all over. They've got 8 hours to urinate on their own. Sometimes it's just a lazy bladder. It takes a minute or two to wake up, or a few hours in this case. So we give them another 8 hours. If they haven't voided again, then we're going to repeat that process. Do the bladder scan, do an in and out catheter, and give them another chance. At that point, if they still are not able to urinate post-operatively, we're going to need to get a provider involved and have the discussion about maybe starting some type of medication that's going to relax the bladder neck so that they can urinate, even if it's just temporarily, and perhaps putting in an indwelling urinary catheter, also known as a Foley catheter, until that medication starts to work and the patient can then urinate on their own. Most of the time, in my experience, it doesn't really get to that point. But once we put in that indwelling urinary catheter, of course, it's going to increase their risk for catheter-associated urinary tract infection. And, we don't want to if we don't have to. But if we're putting a Foley catheter in for retention, then we need to be doing something to treat that retention so that we can take the Foley catheter out. It just can't stay in there indefinitely. So this is when a patient might be started on something like Flomax or tamsulosin is the generic name of that medication. Keep the catheter in for 24 hours and then take it out and start all over again. That way it gives the medication time to work. Sometimes what I do, if a patient doesn't feel like they can urinate and they're not wanting to get up for me, a really good scare tactic is to take a Foley catheter kit in, tell them about what a Foley catheter insertion entails, and set it there on their bedside, just kind of like an idle threat. Oftentimes that stimulates the bladder quite nicely. This is especially effective with the male population. I do also want to mention, and I don't have this on this slide, but since I'm looking at the word electrolyte balance, a couple of things that I want to monitor just in response to whether or not a patient has an NG tube. And at this moment, I don't recall if I have an NG tube on a slide anywhere, so I'm going to just talk about it. Nasogastric tubes are very common in the postoperative patient, especially if they've had some kind of abdominal surgery. One of the things that we monitor is terms of electrolytes for patients who have an NG tube is potassium. I lost it. So hypokalemia. Also, we monitor sodium because of that, but primarily potassium. And we'll talk about, more electrolytes later. We've talked about sodium up to this point, but hypokalemia is one that we monitor. We're also going to monitor in the postoperative patient magnesium and phosphorus. Those are 3 electrolytes that we commonly monitor in those patients. I'm not going to go into it really deeply at this point. We'll get to it when we talk about those electrolytes specifically, but just know that in the postoperative patients, very common, we're watching potassium, magnesium, and phosphorus. And if a patient has an NG tube, we're very concerned about hypokalemia, so something that we need to monitor there. Okay, skin integumentary assessment. So of course, if a patient has an incision, they're at risk for some type of integumentary problem. They clearly have a disturbance in their integument because we have cut them open. It's just the nature of surgery. So we want to be clean when we're touching these patients, use gloves, wash hands, encourage the patient to do the same because they do have an opening in their immune system, right? Because the skin is a huge barrier against foreign invaders from the outside. So infection is something that we always have to consider in what we're monitoring an incision site for. A little bit of redness is pretty normal. A little bit of drainage, serosanguinous drainage. That serosanguinous is kind of like a mix between blood and serous body fluid. So it's not bloody. It's kind of almost like a dilute, sort of watered down blood look. Pretty expected. Not a lot, but some from an incision site. But if we're concerned about infection, in addition to systemic signs of infection, which we're very aware of, we've already talked about that, things like fever and elevated white blood cell count and stuff like that. Local signs of infection for an incision site might be redness more than what's expected, purulent drainage. This is pus coming out from a wound, or odor, right? That's going to be a sign of an infection there. Those are things that we need to take seriously, we need to be alerting the provider to our assessment findings. So perhaps we might need to get a culture after we talk to the provider and whatnot. So we're looking for signs and symptoms of infection. If it is present, then it's going to complicate and prolong the postoperative period for this patient. They're going to need to be on antibiotics to treat the infection. It's just going to be a nasty mess for them. So prevention really is best, making sure we're touching incision with clean hands and whatnot. Dehiscence and evisceration is a disruption in the incision site that can lead to complications. And I have a picture of this on the next slide. A little note about wound drainage and dehiscence. If your patient has an increase in serous drainage, like all of a sudden, that could be a precursor to dehiscence. Your book talks a little bit about that. Now, what dehiscence is, well, first of all, it's the opening of a surgical incision site to a particular level. So a patient's had surgery. It's more common in someone who is obese or overweight because they have increased pressure at that site, especially in an abdominal surgery. Now, any wound can dehisce. It doesn't have to be an abdominal wound, but this is definitely a common one. I've seen a stump wound dehisce before too. But again, the reason is the same. We have an increase in pressure of that site. Could be because they're not splinting, could be because of overweight, could be because they're putting too much pressure on it, like in the instance of the stump wound that I was referring to. It could be like there's infection underneath of there, and it's just like piling up and pulling on the incision. But regardless, what happens with a dehiscence is the wound opens up, and we're starting to see separation of that incision line. So when you're assessing your incision, in addition to looking for signs of redness and infection, you're also looking for approximation of the wound edges, right? That should be well approximated. It shouldn't be open. It shouldn't be gaping. It shouldn't, nothing like that. If you're starting to see that open up, then you have a patient who has that risk for dehiscence. If this occurs, you put a gauze that's been soaked in sterile saline over the wound. You alert the provider. You let them know this is an urgent situation. They're likely going to come up and put that back together. It can be done at the bedside. Maybe they'll bring a stapler with them and they'll staple the incision back together. If it's more extensive, they may have to take them back to surgery to put that back together. An evisceration is an emergent situation. This is when that incision line has opened up and what's inside is now outside. Commonly, we're going to see like intestines on the outside, right? This is an emergency situation. Again, sterile saline soaked gauze is going to be placed over that wound. You're going to immediately call the doctor, and this patient is going to be going back to surgery because they need to fix that stat. With either one of these, dehiscence or evisceration, and evisceration kind of has the same risk factors for as I mentioned with dehiscence, but with either one of these, a patient will often call you in and they'll say, you know, I felt something pop. That's an uh-oh moment. You need to check shit out there because that's never a good thing when a patient who has an incision is like, oh, I just coughed and I felt something pop. So again, it's oftentimes they've gotten up, they've been doing something, they've coughed, they've put increased pressure on that wound, and then they felt a pop. So emergency situation with evisceration. So here you can see on the right-hand side of the screen how that body part is kind of opened up. You're seeing like muscle and fat and stuff there. That's a dehisced, right? That wound has opened up and dehisced. On the left side of the screen, you can see this is an evisceration. What you're seeing there is not muscle, it's not fat, it's actually internal organ that's starting to pop out through that wound. So that's an evisceration. If you Google evisceration, you can see some pretty gnarly pictures. We'll give you a little bit better of an idea of what that looks like. It's always hard to figure out what you're looking at when you're looking at real stuff when you don't have experience, because books have so many cartoon pictures. It's just not realistic. So that's the difference there between evisceration and dehiscence. Here's a couple of types of drains that you might see. I've already talked about an NG tube, which is a type of drain, as is a Foley catheter. But these drains here that you're seeing on this slide are types of drains that might be inserted into a wound area or like a cavity or something like that. And the purpose of the drain is to drain extra fluid out of there. It could be blood that we're trying to drain away. It could be infection that we're trying to drain away. It could be extra fluid. Perhaps the patient had a surgery, and during surgery they've kind of washed out that cavity, and so they've gotten rid of most of that fluid, but they maybe didn't get all of it. It kind of is hiding down in there in the body somewhere, and so they'll put a drain in to kind of help drain that fluid. The one that you see on the left, that is called a Hemovac Drain. I see these not so much in my knee joint replacements anymore, although it was for a while. Let's see, I've seen them in abdominal surgeries. I've seen them in spinal surgeries, but it's a compression type drain. So you squeeze it down, you open up the valve, you squeeze it, you close the valve, and then it kind of self-suctions out whatever it is we're trying to drain out of there. You gotta be careful because the little tube piece that you can kind of see attaches to the top of that drain in that picture can pop off. If that does happen, we do not just clean it off with an alcohol and put it back together. That doesn't work that way. We call the doctor, let them know. They're likely going to have us take it out. We do empty the drainage. We do assess the drainage. We want to know what it looks like and how much is coming out. Ideally, we should see a decrease in the amount of drainage from day to day. High amounts of drainage can indicate problems. Like I mentioned, dehiscence before, it could indicate infection. But we're not supposed to have continuous amounts of fluid coming out. It should also start to clear up as time progresses and goes by. Excuse me. So what may start out more bloody should start to clear up a little bit and turn more towards that serous type of fluid. Excuse me, I got distracted for a moment. Okay, the drain that you're seeing in the middle, that's called a Jackson-Pratt drain. It looks like a small plastic grenade-looking drain. Same type of principle as the Hemovac drain. You open the valve to empty it, and then you squeeze the grenade and then close the valve while it's squeezed, and it provides that self-suctioning. One thing I would like to say about a Jackson-Pratt drain is the piece that's inside of the patient, the length of that might vary, and you never know how much is actually inside when you go to pull it out. This drain is actually sutured in around the insertion site of the drain. So when it comes time to take it out, you have to take this suture out. And when you do take this out, you want to make sure that you decompress the drain, because otherwise it just sucks all the way out, which causes pain. And I've never had a JP drain before, but patients, when they're coming out, get the most awful look on their face, and they say it's a feeling like they've never felt before. It's very uncomfortable. So I typically have them take a deep breath, and then as I pull the drain out in one slow, not too slow, but fluid motion, have them breathe out really deeply. It kind of gives them something to distract them. And I let them know that it's going to be uncomfortable, but it will end quickly. Once I take that drain out, I'm just going to put a little gauze over the insertion site, and that will heal up on its own. It will close from the inside out. There's no need to put sutures or steri strips or anything like that on it. Let's see. Penrose Drain is what you see on the very far right of this slide here. It's just a little piece of like tubular, it looks like like some kind of worm, right? Tubular thing that is open on both ends. Least favorite type of drain, they definitely drain a lot. They're good for wounds that are expected to have high amounts of drainage. You can see that they don't have any collection chamber attached to them. So these are just like draining out there into the open. Very messy. We have to keep them covered with dressings. So we use a lot of those like ABG pads over these JP drains because there's nothing that they're draining into other than the dressing. So frequent dressing changes for these. They also are not sutured in. They're just kind of placed inside the wound. So we have to be careful. Sometimes the end on the external portion of it, there'll be a little safety pin so that they don't kind of fall in to the wound. And it's not uncommon for you to do a dressing change because it's saturated with purulent fluid and it's just completely come out. There really isn't anything you can do when it's come out other than alert the provider and let them know that, hey, your Penrose drain came out. I feel like we have to be almost done. Okay, what kinds of things lab-wise are we monitoring? Well, you can see here all the different things we're looking at. We've talked about different electrolytes to watch for. We've talked about hemorrhaging and how that affects our hemoglobin. We've talked about infection, and we know how white blood cells respond to infection. Glucose might be something that we just keep an eye on, especially in our diabetic patients. ABGs, we look at, that's gonna, if we have that neurologic change, respiratory issues, remember can lead to neurologic changes. We might get an ABG just so we can see what our CO2 and our O2 is. Renal function is done because we're concerned about perfusion as well as hydration. And electrolytes must be very important because I put it on there twice. All right, I guess that is the end of postoperative care. That was pretty lengthy. Hopefully you got all of your graphic organizer kind of filled out there. If you do have questions, please shoot me a message and let me know.